Welcome to the latest episode of Lateral Think, brought to you by Melbourne Athletic Development. Melbourne Athletic Development is a sports and injury management clinic based in Melbourne, Australia. To maximise your performance, optimise your injury management, contact the team at Melbourne Athletic Development. Hello and welcome to the latest episode of the Melbourne Athletic Development podcast. We are very lucky today to be joined by Dr Stephanie Filbay. Stephanie, can you give us a little bit of a background on who you are and what you do?
Sure. Thanks for the invitation to be here. I'm a physio by background, now full-time research. I finished my PhD around 7 years ago now. So I've been in research for over 10 years. My PhD was in the field of longer-term quality of life after ACL injury and looking at comparing outcomes between reconstruction and non-operative management. Now I'm based at Melbourne University doing full-time research into ACL injury and knee osteoarthritis.
I think obviously before the podcast we sent some questions, and the obvious one that came to mind for me was why you chose to research the knee.
Yeah. So I had my own ACL injury when I was 18. So my first year of a physio degree.
What were you doing?
Playing soccer. Yeah, I was a striker and it was an illegal tackle. So
of course.
Contact injury. Yeah, it was. And so I underwent reconstruction. I had some challenges getting back to sport. And then once I got back, I re-ruptured and underwent revision surgery. And then I re-ruptured the graft after revision surgery and didn't have another revision.
I feel like that's a very good motivation for wanting to work out how to make this injury nowhere near as bad as what it has to be. You've got that first-hand experience, which I'm sure for you is probably part of what makes it easier for you to be able to actually conduct this research. It's probably motivating as well because there is that element of, empathy towards what these people are actually trying to do. You've probably had maybe one of the worst sort of outcomes when it comes to re-injuries, and it's never a great outcome when people have multiple re-injuries.
Yeah, it has been challenging, and I did have osteoarthritis since I was around 25. The pain, always a painful knee, swollen knee, and very difficult to be active. So sort of trying to balance wanting to be really active and taking part in sport with a knee that has deteriorating function over time. So I faced those kind of challenges as well. Even when I reflect back, like my mum had an ACL injury when I was very young, and my dad and two uncles had to sort of end their Aussie rules career early because of ACL injuries. So I think it was also probably around me from a young age as well without really realising it.
This is probably a difficult question to answer, but why do you think you didn't have a successful outcome with your reconstruction?
Well, as we know now, my outcome wasn't that uncommon. I fit that profile. I did fit that profile of a young female soccer player returning to soccer. So we know that 1 in 3 with those characteristics actually re-injure their ACL graft. So that was me. And my re-injury or my graft rupture was the exact same mechanism as my initial injury, to the extent of running along the same side of the field, the exact same tackle, took my leg out, got a red card, and re-ruptured my graft. So I guess I
somewhat unavoidable.
Yeah. The surgeon was happy. He thought that meant it wasn't the graft that failed because it was the exact same mechanism. But yeah. So I guess I put myself under those high risk conditions again, being sport. And once people re-rupture or rupture their ACL graft, they have poor outcomes. There's a lot of evidence to show that. So yeah.
You brought up the difficulty of it, and I think some of your researchers looked into people's return and how they deal with that. Is that coming from some of that personal experience of understanding how difficult an injury it is to come back from that sort of motivated you to want to look into more of that? Because even we're clinicians, as you've been as well, and that actually that those conversations are often the more difficult ones to have with people, because they start asking questions like, we just mentioned, how am I going to go getting back to sport? And the reality is the evidence suggests that it may be quite difficult for them. And you have to be very open with them about that. So, is that something that you wanted to look into and understand a little bit more with your research?
Yeah, absolutely. I mean, reflecting back, I was never really informed of the risks, I suppose, of returning to sport. If I was, would I have listened? Probably not, anyway. But some of my earlier qualitative research, it found two separate subgroups. So those that quite enjoy being active through gym or jogging, recreational activities, and they tend to have so many challenges in terms of quality of life after ACL injury because they can adapt their activity. Then there's this other subgroup who, really get fulfillment from competing in sport, whether that's Aussie rules or soccer or contact sport or combat sports. And these people often struggled if they couldn't get back to that injury level of performance, or actually back to that pre-injury level of sport psychologically. And I guess I fit that description in terms of I'd always taken part in competitive sport, and it was really important for my own well-being and quality of life. And trying to kind of understand that through research and capture that drive and what drives people to want to return to these sports, even though their knee is at serious risk of deteriorating in terms of function and likelihood of developing OA. So I'm doing a bit of work around that now in terms of research, looking at how we can get people involved in activities that meet their personal needs, but maybe without that same high risk of re-injury after ACL injury.
What's the general response been with that? Are people in any way sort of resistant?
So, early on, I mean, ACL is most common in teenagers and young adults and young people. So many young people that do their ACLs, all that matters to them at that point in their lives is, can I return to sport? When will I return to sport? What treatment option will increase my likelihood? That's all that matters to me. So I think a lot of people aren't ready yet to hear or to be open to actually what that might mean if you then went on to re-injure your ACL after surgery, for example. Or they may hear that and brush that aside. But that's why it's interesting speaking to people that can reflect back to their earlier selves and maybe think, oh, maybe I should have done things a little bit differently, or having information that they now know that they didn't know then, would that have changed their pathway and their potential outcome? It's difficult. And a few of our studies actually have shown a really strong association between returning to sport and long-term quality of life. So it does matter, and it is important for people's quality of life, even though it may be associated with an increased risk of re-injury. So we need to consider that as physios as well. We shouldn't just say, you shouldn't return to sport if you can change and just go to the gym or maybe play, God knows, golf instead or something like that. We really need to consider the patient's quality of life as well and what they find fulfilling and what their psychological needs are in terms of exercise.
I was going to say then, with that in mind, Steph, do you think it's useful then to psychologically profile people, like similar to what you're describing before about what's their openness to being still physically active in activities that are not necessarily as demanding or have high susceptibility to re-injury, particularly in, say, non-professional athletes? Do you think that's something that's important that we need to look at further?
Well, I'm supervising a PhD student at the moment, Emma, and what her PhD is aiming to do is to look at the association between psychological profiles and people's exercise motives. So whether they, exercise for weight loss or appearance or competitive or other elements. And can we use some psychological tests to actually help personalize activity choices, so that we can help people find an alternative activity based on their unique personality profile, if you will. So that's something we're looking into at the moment. It's still a bit premature in terms of having any results of that work. But hopefully, I think there is potential as physios to consider psychology more in terms of our interventions and in terms of personalising management strategies.
Do you think that means that we probably need to do a little bit more work in the education of physios on that sort of psychological side of things, or is it more bringing in, say, psychologists as part of that process? It's a very clear part of what is going to happen in your ACL management, that as you go through this process, you're going to see this person, this person, this person, all of these professionals are part of your sort of return to, whether it's return to play or return to activity team.
Mm. Yeah, I think there's definitely potential to upskill all physios in terms of considering psychological aspects in their care. I also think there's probably scope for, like we have professional development courses or specialization for something like a physio with extra specialization in psychology and psychological aspects. Because as physios, we have very useful skill sets and a very useful knowledge base and understanding of a lot of other factors. And I think to upskill some physios to also have more understanding in terms of how to address mental health issues and psychological aspects could be advantageous. But where you don't have those skill sets, which a lot of physios don't at the moment, referring on is really important, and recognizing actually they may benefit from some more psychology input, which I don't have the expertise in. So referring on to a psychologist or sports psychologist. Yeah.
I was looking at one of the questions we put forward to you was looking at your recent publication of looking at the potential healing of ACL without surgery. And it's interesting because one of the things I thought of is there's obviously been so much research into management of ACL injuries, and the general conventional wisdom suggests that you need to get surgery followed by X amount of rehab. But some of this research is highlighting that perhaps surgery isn't always going to be the case, that there is a subgroup of people who may actually get healing of their ACL conservatively. So I was interested to hear about this research, but I was also interested to hear your thoughts on why has it only become more evident recently that that the ACL actually has the potential to heal by itself?
Yeah, really interesting question. I don't know the answer to why more people haven't looked at this earlier. I would say that people just tend to not challenge long-held assumptions or long-held beliefs. Society can think this is just the way something is and sit with that without challenging it. And there have been a few smaller studies here and there that have looked at generally spontaneous healing. Usually there's some partial ACL tears in that cohort, but none of it has really taken off or had sort of wide-reaching impact. So our recent investigation in the Canoon trial, which was published in BJSM earlier this year, it has had a lot more attention and more wide reach, partly because of the quality of the clinical trial in terms of the cohort and the data that we had available. And also it helps to publish it in a really quite high impact journal like BJSM, where a lot of people follow that, and it can get dissemination of findings out there as well. But of course we needed MRIs to be available before we can really understand what's going on with the ACL. But they've been around for over 10 years and people have been collecting MRI data. But I just think often in studies of non-operative management, so where there's a rehabilitation arm that haven't had surgery, people just really haven't thought to look at the actual healing status of the ACL, which is kind of crazy when you think about it, but it's just been assumed that that's not important because it doesn't heal. So, yeah.
Was that quite surprising for you and the research group to see the actual prevalence of people that did get healing of their ACL non-operatively?
Yeah, I think it was surprising, especially in that group, in those who were managed only with rehabilitation, where 53% had a healed ACL at 2 years. That was surprising, but even more surprising was the fact that they had better outcomes, not only than those with no healing, which maybe we'd expect, but also better outcomes than those who were randomized to early ACL reconstruction. So that aspect was surprising and wasn't really expected.
Are you starting to get an understanding of potentially the profile of people that do get healing? Like, has it got to do with the way that their inflammatory markers are, the immunological system, how their, what their previous, maybe histories of injury, all those kind of things, genetic profiles. I'm obviously,
or even some of the characteristics of the rupture itself in terms of location of proximity,
or is it too early to tell?
Yeah, so within the Canoe trial, so that was a randomized control trial where people were randomized to initial rehab and optional surgery or initial reconstruction. Within that trial, we haven't looked at any predictors, if you will, or prognostic factors of healing, because that's subgroups, the sample size is too small to look at those factors in that study. But we are performing another study where we're evaluating the cross bracing protocol, which is a novel bracing protocol that braces the knee at 90 degrees flexion for 4 weeks, with the thought that at 90 degrees and greater of flexion, the ruptured ends of the ACL are in closer proximity. So by reducing that gap distance, that may be more likely to have a bridge of connective tissue and to facilitate healing. So that was the initial idea behind the bracing protocol. We've published a conference abstract and the paper's now under review for the data from the first 80 patients managed with that bracing protocol. And using the same criteria as the Canoe trial for healing, 90% had a healed ACL at 3 months follow-up. So that's 3 months after going through the brace. And the bracing protocol is more complex than just the 4 weeks. It takes 12 weeks and it includes medical and physio-based rehab and other elements, and that will be published in the paper. But in delivering the cross bracing protocol, Tom Cross has now braced 300 people in clinical practice. And there have been some patterns that have become apparent in terms of factors that might be important in predicting who will have a good heal or a high grade heal. So we're designing a study at the moment to look at predictors of healing after use of the brace. I can shed some light on some factors that may be important, not investigated yet in terms of data analysis, but some of the variables that we'd like to look at. So time to brace, we think that if there's a longer time since injury from which the brace begins, you're probably less likely to have a good heal. The gap distance, so if on MRI you can see a large gap distance between the two ruptured remnants, especially if one of those ruptured remnants is involuted, so it's started to round over, they're probably less likely to have a high-grade heal. Avulsion at the femoral insertion, so a partial avulsion or complete avulsion may be a less ideal candidate for healing. And then disruption of the ACL fibers. So some people we see, especially that distal part of the ACL is flipped or sitting anteriorly or laterally outside of the intercondylar notch. In clinical experience, we think it's less likely that ruptured portion will sort of align and rejoin with its other half. So some of those variables, we think there's lower rates of the grade 1 heal. But a lot of them heal, but they heal a bit more thinned or elongated. And we don't really know how a thinned or elongated heel compares with, say, an ACL graft, because their problems actually look pretty good and higher than what we usually see post-surgery. So even though it's not as good as a perfect heel that looks like an uninjured ACL, it may actually be comparable with what we see after ACL reconstruction. So there's lots of factors to consider and lots of areas that need further research.
Has there been a lot of follow-up now on the return to sport for these people and what effect that has? Have they been able to go back to the activity level to previous that they were participating in?
Yeah, so in the bracing protocol, we've got the Canoe trial and the bracing protocol, but after the brace, in those with a grade 1 heel at 3 months, that's continuous ACL, but increased signal on MRI or slightly thickened. So 92% of those had returned to sport by 12 months. And most of these sports were high-level rugby, Aussie rules, contact, competitive, pivoting sports. And then in those with either, I'm going to say a grade 3 or grade 2 heel, so that's thinned or elongated but continuous, or discontinuous, so non-healed, 64% returned to those sports. at 12 months. And that rate is more comparable with what we see post-surgery. To complicate things further, out of the first 80, only 8 didn't heal. But 6 of those 8, actually, their ACL sort of fused and attached to either the lateral wall or the PCL, which I know sometimes we see in clinical practice. So although we called them a non-heal, that could provide an element of functional stability that we're not really aware of yet. So it's hard to distinguish between those different signs or grades of healing and how that might impact on function and promise. But yeah, so a very high return to sport rate amongst those with a high grade heal, amongst those 92% had returned by 12 months. And most of them, we've done a qualitative study as well, exploring their experiences. A lot of them feel as if their ACL is never injured, especially there's a subgroup who've also had reconstruction on their other knee, so they can compare both treatment options and how their ACL feels afterwards. So a lot of those prefer the cross-bracing protocol, but also how their knee was and their ability to play sport after the bracing protocol and healing compared to reconstruction.
I was just going to say that's an interesting thing to consider of the psychological implications to having surgery itself, because I guess in terms of the severity or even maybe the thought of like, it's not as it was before, which I guess it makes sort of sense when you think it's an actual graft that they're using and how that can have potential long-term implications for how they view their body and the potential success of their outcome long-term.
Yeah, well, interestingly, another study that we're doing, one of the findings that came up through that study was as physios having that knowledge, we might think that way, but actually some patients get the psychological benefit from surgery because they believe that surgery is fixing their ACL or that they're just replacing it with a new one and that's a sure thing and that's a fix. And so afterwards they get relief in that, oh, my ACL's been fixed or it's been repaired. But in reality, that isn't what the surgery entails, and the patient generally hasn't been adequately informed. But, is it in their best interest? Yeah, it's kind of complicated in terms of the placebo effects around that when, that was a finding that physios in Australia recognise that some of their patients experience a psychological benefit from the surgery based on their preconceptions and their beliefs.
Mm-hmm. Do you think that would change in different populations? I know that in Australia particularly that is considered, the gold standard is to have the surgery and sometimes sooner rather than later. But there are obviously parts of Europe where that was popularized for non-surgical management to be at least trialed early on. And it's interesting I think that there's potentially like cultural effects that are related to, especially in a country like Australia. Professional sport is, people really enjoy being involved in that. And we have a lot of understanding, I actually think, of things like ACL injury because of, the field sports that people play, rugby, soccer, football. And we see some of our favorite players, missing a season or whatever it is because of an ACL injury. People's understanding of what that is and how that actually plays out is actually, I think, quite common in the general sporting community, even if it's people participating at community level.
Yeah, we've got deeply ingrained misconceptions in Australia when it comes to management options. Even you using the words saying that surgery is the gold standard. The recommended evidence-based approach is 2 options and weighing up the pros and cons between the 2. And there's multiple guidelines, evidence-based guidelines now recommending trialing rehab first before considering ACL surgery. So that's evidence-based practice. In terms of what's going on in Australia is not evidence-based. As we know, around 90% of people have surgery. And as you say, there's a lot of beliefs that surgery is needed to return to sport and that surgery is the preferred treatment option. Within elite sport, they'll be the last to adopt evidence around non-operative management. And it's largely because they have unique demands. So that's not demands on the ACL, it's demands on the athlete and the team in terms of getting the person back to sport and predicting the length of return to sport. When weighing up the pros and cons of surgery and non-surgery, one of the only cons of starting a non-surgical approach is the uncertainty around the timeline. because if that person then goes on to be someone that would benefit from surgery after trialing rehab, they've delayed the whole recovery process. Typically by maybe 3 months, if that's how long they've trialed rehab for, but even longer if perhaps it's gotten to 6 months before they've realised that surgery may be beneficial for that person. So elite sports generally can't take that risk in terms of possibly delaying it, even though if they are successfully managed with rehab, they can return faster and perform faster. But that sort of risk and element and lack of control and ability to predict that non-operative route, I think, is one of the reasons why reconstruction is still just common practice. They just get someone in as fast as possible to have surgery. Yes, so it would take quite a while to change societal beliefs, I think.
Yeah, well, I think you raised an interesting question, or an important point here of actually pursuing conservative management as one of two options. Do you think then, to putting aside the potentially using the bracing protocol, which I want to ask a bit more about, if you do begin with conservative management, do you think it's actually worth then getting another MRI before you even consider a surgical opinion at 6 months to see what has changed in whether the actual ACL has healed?
Yeah, so interestingly, in both the bracing protocol and the Canoon trial, we did see that signs of healing were apparent on 3-month MRI, which isn't that long to wait, really.
No, it's not.
We don't like to advocate lots of imaging for people for costs and other reasons, but my belief is in the future it may be a really important part of the puzzle in determining who'll benefit from surgery. And someone like elite sport have the resources to definitely do a repeat MRI after 3 months. Within the Canoon trial, the patients weren't aware of the healing status, and neither were the clinicians. It's not something that they looked at the time. Despite that, in those who decided to have delayed surgery, almost all of them had a ruptured ACL at 3 months, so no healing. Whereas in those who went on to have rehab only and didn't want to have surgery, much higher number had signs of healing at 3 months. So it suggests that it plays a part in copers and non-copers, if you will, or in that pathway of who has successful management with rehab or who decides to have delayed surgery. So, yeah, I think it may be valuable, and it may be almost one of the missing pieces of the puzzle in terms of predicting who will do well with rehab only.
The thought that came through my mind when you mentioned elite sport, do you think that, and this is probably a question that's maybe not been looked at too much, but do you think that we actually limit what we research because there is influence from elite sport into, these kind of things? I think that particularly for, say, an ACL injury, which is heavily associated with physical activity and particularly with sport, that some of the research has actually been held back by the practices that do occur at the elite level.
Look, I don't think so, but the one thing it does limit is the generalizability, because it's very difficult to do studies in elite athletes. So the majority of the research has been performed in non-elite, high level, state league even, and competitive sports, but not professional. So we can't quite generalize to those cohorts, which then can affect uptake from the top down. This research doesn't include us, professional athletes, so it means it's not applicable to us. So we don't know if it would work for a professional athlete, for example. In reality, they have a lot more resources in terms of their rehab, and so there's no reason why, why it would be any different in elite athletes, I don't think, especially because the rehab can be performed to a very high standard. But yeah, that's the limitation, is that it affects the generalizability of research.
Do you envisage a time when it will become the evidence-based model will be very much towards non-operative management? It sounds like the early signs of the research that you guys are doing is actually very positive. And I think it's music to all sort of physios' ears to think that, non-operative management may be beneficial, but I can probably hear the orthopedic surgeons crying, into their headphones as we talk about this, because I'm sure they probably don't necessarily see it the same way at this point.
I think that I do see a shift happening globally, but even in Australia as well. And this piece around healing may be able to help that shift, if you will. I think people like the idea that actually their ACL can heal without surgery, whereas there's some aspect of just rehabilitation wasn't really satisfying people as a treatment option because the uptake is so low. Again, in their head, I can get it fixed with surgery or replaced with surgery or learn to cope without an ACL, which was the belief that why we do rehab, right? So the patient's always going to choose, they're wanting to return to sport, well, I want to have it fixed over coping without. I don't want to have no ACL compared to an ACL, even though, a graft doesn't reflect an uninjured ACL, but they often don't have that understanding. So if our knowledge adapts or evolves to understand that a proportion that have rehab will actually, the fibers will come back and the ACL will heal and become continuous again, then the uptake towards that non-operative approach may be much higher.
Given that there is evidence from your work that some people will get healing without actually bracing, do you think it will get to the point where we'll be able to get good indications of subclassification of saying, okay, you will have a good outcome with bracing because of the nature of the ACL injury, but there will also be some people who will also have a good outcome who don't need bracing? Or do you think it will end up being most people will get braced if they want to actually avoid surgery?
So I think, first of all, the changing belief that it is possible for an ACL to heal. That's the first sort of big aha moment. And then from there are a lot of different treatments that we could trial or approaches that we can think of. If one of the aims of ACL injury management changes to be, can we facilitate healing? There may be other ways of doing that rather than just bracing at 90 degrees, for example, firstly. Secondly, we don't know, perhaps there's types of ACL ruptures that are more likely to heal with rehab. We don't know. There's a lot more research that's needed there to try to understand that. Yeah.
Are there many people in Australia, like apart from Tom Cross and his group, that are implementing bracing for ACL management? Like, are there people in, say, for instance, Melbourne or other areas of Australia or the world that are doing it as well?
So there have been groups that have tried various different bracing approaches, including a group in Japan and a group in Switzerland, I believe, which was the ACL jack brace. But none of those were bracing in flexion or at 90 degrees flexion. So that's what's novel about the cross bracing protocol. The group in Japan were, I believe, bracing at extension, which kind of counteracts the principles of the bracing protocol because it's actually where the ACLs in greatest proximity apart. So widest distance apart, so it's sort of the opposite principle. Since we've been presenting on the bracing protocol data and the conference abstracts been published, a lot of people have been contacting wanting to use the bracing protocol in clinical practice, and some have been doing so. The caveat to that is the protocol is not yet published and it may be unsafe. For example, a really important element is DVT screening before bracing and DVT prophylactic medication to ensure someone doesn't have a DVT if you're bracing an acute ACL rupture at 90 degrees. But when people are kind of hearing about it and then trying to implement it without having the full protocol, we've heard cases of people doing that, without thinking about DVTs, which could be quite dangerous for patients. So hopefully that will be out and published soon. It definitely is being more widely implemented already before the data is actually published. We're also been performing it, so with Jane Rooney in Melbourne, group in Gold Coast, New Zealand, some people in the UK, Japan. So around the world have kind of started trialing the cross-bracing protocol. But I should mention we are designing a randomized controlled trial at the moment, which I believe is needed, to compare outcomes between the cross-bracing protocol and ACL reconstruction.
Yeah, that'll be super interesting. I think that probably starts to go down the path of validating where this sits, and I think a lot of clinicians will obviously be very closely tuned into what happens with that. I wanted to ask you, obviously, a large part of your research, and you mentioned that even at a personal level, is related to osteoarthritis. Can you give us a little bit of an idea of some of the things that you're looking at with both the relationship between ACL injury and osteoarthritis, and then some of the quality of life studies that you've done in relation to osteoarthritis?
Sure. So one of the sort of bodies of research, I suppose, that I've looked at is predictors. So who will go on to develop osteoarthritis after an ACL injury and who won't, in terms of looking at functional measures and things that we can assess in the clinic, but also patient factors and patient characteristics. Yes, we've found some candidate prognostic factors, but there's no really strong, we don't quite yet know, with any sort of consistent certainty who will go on to develop osteoarthritis. We're then looking at the intervention piece. So I mentioned trying to understand activity motives to get people active that have OA after ACL injury, because we know physical inactivity is a risk factor for OA progression, especially if someone puts on adiposity and puts on weight and things as well. So understanding psychological factors to personalize activity choices to get people active again after ACL injury. So that's related to knee OA as well. And then the quality of life piece, I've done quite a bit of work exploring quality of life in people with long-term symptoms after ACL injury or symptomatic OA. And one of the things that comes up as being really important for these people is their ability to take part in sport, not surprisingly, and exercise, but also like things like for their competitive need to be met and their confidence that they have in the knee or fear of re-injuring their knee. And this is, 5 to 20 years after ACL injury. So I think as physios, when we manage people with OA after ACL injury, we just need to be aware that they have some unique needs from a typical older OA population. They often still have desires to be competitive and to take part in sports, and that is often ingrained with their quality of life. So just to really address those sort of elements with patients and come up with a plan to get them active again. And in some cases it's, if someone sports rugby and they can't play because they're knee OA, what is it you love about rugby? What is it that satisfies within you, and how can we find another activity that you can participate in because of your knee that'll meet those needs, that'll allow you to be active across the lifespan? So, doing a bit of work in that space as well.
Do you find that you're starting to develop good strategies for being able to help people plan that, or are you not at that level yet? Because I think, as clinicians and we have a team of staff as well, like we're always talking to them about, establish what the expectations of this patient is. And, you're trying to help them achieve what they want to get out of not only their physio journey, but also, their physical activity and those other factors. So, have you guys developed, certain protocols that you use or strategies to try and, understand that better and be really clear with the patient so that you can, whether it's refer them on or even just give them some opportunities to explore those things? Because as you said, not everyone is going to be able to return to that competitive activity in the same way that they, would have in the past.
Yeah, we're developing a new intervention, so a physio-delivered intervention that will likely have different elements, and the first element, which will include identifying activity recommendations based on their personal characteristics and motives and psychology. But then it will involve goal setting tasks, but actually taking that next step of locating those activities in the community so the person can go and participate in them and report back. Did that meet your needs? Did that overcome your barriers to activity? If not, let's find another activity. So really actually working through those steps with the patient until they're engaging within that. So it's not just saying, what I think surfing or rock climbing would be great for you. Off you go, and my job's done. It's actually getting them to engage in it, following up that it's meeting their needs. And I think once we reach that level, the likelihood for that person to continue participating in that activity into the future is really high, especially if it overcomes the barriers that are relevant to them. So where was I going with that? So we are developing an intervention that will be freely available to physios, and a digital toolbook, if you will, that you can work through with patients in different sort of throughout typically 3 to 4 consults.
Yeah, awesome.
So that's in the future. Yeah, we're working on that.
With the you mentioned there was some sort of brief prognostic indicators for why someone may develop OA earlier, who's had an ACL injury. Can you describe a little bit of that? Because I think I personally even sometimes struggle to be able to articulate that to patients who ask, because they're made aware that their knee's never going to be, or not definitely, but some people do not have the same outcomes, and they can develop osteoarthritis earlier. Can you give us a bit of a background and understanding of what you believe potentially is contributing to that?
Yeah, and the evidence is, I'm going to say, complicated here. One of the reasons is most studies use radiographic OA as the outcome, not symptomatic. We know that symptomatic and just what you see in radiographs are poorly correlated. And doesn't matter if you have radiographic changes if you don't have any symptoms. So that's one of the complications. And the other one, there is a lot of conflicting evidence where some reviews or some studies find a prognostic factor and others don't. So it isn't clear cut. With that being said, some things we do know. So we know that, for example, graft rupture after ACL injury is associated with a high risk of OA development. And we're starting to understand some factors that may be related to an increased risk of graft rupture. So you can then connect the dots. So, for example, poor knee function, worse knee confidence and readiness to return to sport at the time of returning to sport can increase the likelihood that you'll re-rupture your graft, which in turn can increase your risk of osteoarthritis. Often we draw upon the more general OA literature to look at risk factors for OA, including obesity, for example, and we assume that the same risk factor would apply post-ACL injury, although the evidence isn't as clear. If that's the case, weight gain and physical inactivity may be a risk factor for developing OA. We know that meniscus injuries, strong predictor of osteoarthritis, both concomitant at the time of ACL injury, but subsequent as well. So preventing further knee injury, especially damage to the meniscus, is important in preventing osteoarthritis. That's the main ones. I mean, there's often early signs in the people that have poor knee function on things like hop tests, and in some cases weaker quads or hamstrings within the first few years after injury go on and have worse long-term outcomes, more pain, worse function 10 or 30 years later. So they're the sort of factors that are likely to be important.
Given that one of the ones that you mentioned there was, related to general health in obesity, do you think it's something that, we need to be planning around a little bit more of making sure that people's general health stays, at a high level during that period post ACL injury, especially if they choose not to go back to, say, the same level of physical activity participation? Yeah,
I think it's important to be thinking about lifelong physical activity. There may be some benefits from not returning to a contact, high-risk pivoting sport like Aussie rules or rugby. But also there may be negative impacts from quitting all sport altogether. So there's likely an ideal middle. For some people, returning to sport is important for their well-being, and they're likely to do that anyway. But just educating people that are actually the potential negative impacts for their osteoarthritis risk and their general health in the future if they adopt an inactive lifestyle. So, helping people make a healthy transition when they're ready to make that transition from competitive sport to participation in other activities.
That brings up a question I've thought of too with regards to healing of the ACL conservatively, is whether there are some factors related to systemic health, say, would it be something like overweight or obesity or other markers of cardiovascular function or metabolic health that influence the strength and integrity of the ACL healing over time? Is that something that is there any indication that may be something that's relevant, or is that something that you're interested in looking at moving forward?
First thing to say is that we don't have any information on this whatsoever. The other thing in both these studies, so in the Swedish Canoon trial, people were active, so they're healthy weight, active, young to middle-aged adults. Similarly, in the cross-bracing protocol, everyone's taking part in sport, meaning we haven't really studied it in people maybe with a higher degree of adipose tissue or even with higher BMI. We haven't really looked in those populations at all. But we've even had some queries around nutrition and diet in terms of healing. Patients ask, is there anything I can eat or any supplements I can take that might increase the likelihood of tissue healing? Of course, we don't know. There's possibilities, there's lots of potential, but no idea.
Yeah, that brings up, it's becoming a popular area, I think, particularly with a lot of the research looking at collagen and the use in tendon injuries of, whether other connective tissue structures will respond in healing in relation to nutrition. So, and I think, a colleague of yours and a friend of ours who works with you, Adam Bryant, spoke about the idea of follow-up they did where they showed that immunological function and cytokine sort of numbers were much higher in a post-ACL knee, even 2 years post reconstruction. So it starts to bring forward, and we don't have any answers and we're just posting questions, but whether there is opportunity in the future to really closely monitor someone's general health and how that may actually affect their healing. I think that's a really interesting area that at the moment I don't think any of us have enough information to be prescriptive, but it probably opens up some really interesting and particularly individualized sort of healthcare in the future. So I think that's a bit exciting.
Yeah, and with new emerging technologies in terms of how we can now begin to track and monitor people's health and other variables over time with wearable technology and other things, I guess gives rise to the possibility of lots of new research designs or new potential questions that can be explored.
What kind of research designs do you think are sort of coming that at the moment we don't necessarily see as often? But I guess yourself, you're a young researcher. What are the things that you would like to see implemented in terms of research design in the next sort of 10, 15, 20 years of your career?
In terms of what I see a change in where a lot of research is going, machine learning and AI in terms of, so I've talked a bit about prediction and prognostic studies. If we can get the right data and enough data and large samples, for example, when it comes to ACL injury, the future may be that we can look at a MRI baseline and an AI machine learning model may be able to tell us the likelihood that person may be able to heal based on what they're seeing on that MRI, or even a 3D image of an ACL. So 3D imaging is another advancement which would provide a lot more information or data points for potential machine learning or otherwise to predict or to form an algorithm. So in terms of that kind of research, there's a lot of advances in that area, or potential, should I say. And then in terms of wearable technology, it provides the potential to provide almost a continuous data collection. So we get so much more information about someone's lifestyle and everything from sleeping to heart rate to diet to even the ability to collect repeated proms about how someone's feeling at a potential point in time and how that changes over the day or the course of the day. So it can really flip the way we explore research questions and the sort of things we might find, especially with conditions that fluctuate, like OA symptoms, where someone may be pain-free and then have a flare, or even post-ACL injury. That's something we commonly see. So we can then look back and start to understand maybe what preceded that or what may be related to that flare, and both psychological function or behavioural aspects or loading or other elements. Yeah, so there's some directions of research there as well. But I think in terms of orthopedics, and I'd put ACL injury into that bracket of orthopedics or ACL surgery, just using, clinical trial designs are needed in a lot of elements. There's a lot of evidence lacking for a lot of surgical procedures that are performed as first-line treatment in Australia. So in some areas, we don't need new innovative designs or technologies. We just need the research and the resources and the funding to perform the research for a lot of surgeries that are commonplace today.
I'm actually interested to hear what kind of surgeries are you referring to?
ACL reconstruction is a good model, right? Where still 90% of people are having reconstruction, even though now we have 2 clinical trials showing no benefit of reconstruction over rehabilitation alone. But yet it's still commonplace. That's still only 2 clinical trials, and there's a lot of other elements with fewer trials. So meniscus surgery would be one. There was a good research design, a placebo comparison arm for meniscus injury, a finished study that really helped to shed light on the potential lack of benefit, especially in meniscal surgeries for degenerative meniscal tears. But we still don't understand a lot around meniscal resections, meniscectomies, and how that compares with rehabilitation. There's evidence suggesting that there may be little benefit of surgery versus rehab. So it's following a lot of similar patterns to ACL surgery, but there's a bit of a lag in terms of there's even fewer studies in that space when it comes to the meniscus. So
I imagine it's hard to get ethical approval for a sham ACL reconstructive surgery, is it?
Yeah, it's not going to happen in Australia. Hopefully our colleagues in Finland can lead the way there. They seem to, and even in Norway and other places, they seem to have more success in getting ethics, but also patient buy-in, right? You still need patients to sign up to these studies to potentially have sham surgery. So there is a different research culture. Sweden is one place with a terrific research culture. We followed people up 32 to 37 years after their ACL injury, and we got a response rate over 90%.
Oh, wow.
That participated that much longer in the study, and you just never get that in Australia. It reflects kind of the culture that people sort of, I think, they're really happy to contribute to society and community through research participation, which is great.
Do you lament the general culture of science and the understanding of, as you said, that contribution in Australia? Do you think that is something that, I don't know whether it's changed, but whether it's something that you would love to see be a little bit different, where people are much more interested in being involved in research?
Yeah. How do we create that change? I mean, there are some people that are really happy to be involved in research, which is great. But, in terms of equity, say in research and clinical trials and generalizability, we need to make sure we're including a really diverse sample of people, generally that are representative of the population. So if it's the same kind of people that are always putting their hand up to take part in studies or that are happy to participate, which in a lot of ways it is, we need to kind of understand who isn't putting their hand up and why not, and how can we engage those people. One of the good things now is a lot of research does provide compensation to people taking part in studies. So whether that's a gift voucher for your time, it's better than nothing, and I think it's good. I think we should offer people some compensation for taking part in research.
We probably won't hold you up too much longer, but one question that we always tend to ask people, and it can be in more of your own time or something that is related to your profession, but something that is interesting you and you're exploring yourself in your own learning at the moment. I know that curious people, which it sounds like you are very, very curious, tend to have a number of different questions burning through their brain at most times of the day. What's something that's getting at you at the moment?
Gosh, that's a hard question. So not related to work.
Well, it can be related to your research, but it might be
Yeah.
related to something else that you're doing in your own, even your own time.
Uh, hmm. Yeah, I think, I mean, a lot is going on work-wise, so I don't have a lot of free time at the moment to be exploring, solving the philosophies of life or whatnot right now. But yeah, so one of the studies that I'm sort of leading at the moment is developing a patient decision aid for ACL injury management, so that patients can weigh up the pros and cons and make a decision based on their values to have surgery or to have rehab, to provide an overview of the evidence in a way that they understand. But as part of informing that, we've done a big, large body of work, and we've done 2 Australia-wide surveys, patients and of clinicians. So that's been really interesting, those results, and there's also been 2 qualitative studies, because we found that 90% of patients in Australia were told by a surgeon that surgery is the best or only option available to them if they want to return to sport, and 65% of physios gave similar advice. And a lot of really interesting sort of themes have come out of that work. So anecdotally, as physios, I think we sort of understand that there's some biases and things going on in the care pathway, but we don't really have any research to back that up. So I think, this work will be quite interesting. So to get back to your question, one of the things I'm pondering on is, how can we really change practice and make a difference to people's lives by translating the evidence into current practice and into change. And so we're moving into the area of, yes, we're creating this decision aid, which will be an interactive website that's freely available. We're also producing training materials for physios to upskill them in ACL injury management and the evidence that are available for free, so online training modules. So thinking about, it's just how do you, the research might be there, but it's not changing practice. So how do we make that link better? And I think that's one of the questions, and I'm working with and some strategies around sort of achieving that.
Yeah, fantastic.
Well, I was just going to say that I think your research is already quite interesting and pioneering, so I imagine it probably takes up a lot of your time thinking about what to do next. One question I actually wanted to ask before we finish up is, we've talked a lot about the actual healing of the ACL, but the other part of the equation is the actual rehabilitation process. And a question I wanted to ask you was around this idea of, say, perfect or best practice protocols for ACL management, because there are lots of different protocols out there. And I'm interested to hear your thoughts for clinicians, for physios who are involved in someone's rehab process of, how do you think we need to go about approaching that? Is there a gold standard or best practice way for doing a protocol, or do we need to think a bit more broadly about the idea of what we do for someone in their management?
Yeah, I think the recommended or gold standard that involves certain, I'd say, guidelines, it should be personalised to the individual patient. That's really important. So it isn't a one-size-fits-all when it comes to rehab. It should be goal or criterion based in terms of its progression, not time based. It's not saying this for 1 week, 1 month, and then this for the next month. It's let's try to achieve these goals, and once we achieve these goals, we'll progress on to achieving these goals. Recognizing that achieving these goals are all necessary to achieve your longer term goal, which for a lot of people may be return to sport. We know that having certain criteria or some testing before return to sport may be useful for the individual, especially in preventing graft re-rupture. We know that certain tests have been recommended, and there's some various alterations in terms of exactly what tests you should have in that return to sport battery. But there's a lot of overlap, and so there's no definite right or wrong. It's probably useful to have, at least one HOP test, at least some self-reported measure of readiness or psychological function or confidence, and often strength, for example. So going back to rehab. So I don't think there's a one size fits all. I think there's a lot of good resources out there. that physios and clinicians can access. So there's Aspetar released a recent clinical practice guideline for rehab after surgery specifically. And there's also, which I was involved in, the OptiKnee consensus, which includes recommendations around rehabilitation. So both of those resources are good and freely available, and they're good because they involved extensive literature review to inform them. There's other guidelines that's expert opinion, having people sitting in a room and agreeing on certain things, but not evidence-based. So I'd recommend the more evidence-based guidelines. But in saying that, there's different guidelines out there to refer to those resources, but then personalize the choices based on the preferences and the needs of your individual patient.
Fantastic. We won't hold you up any longer, but it's really clear that you have a passion for trying to get the best outcomes for patients, and you want to actually make sure that the research is directed towards changing practice for the better outcomes for both patients and seemingly clinicians as well. So thank you very much for your contribution to the industry, and thank you very much for your time. We know that you're extremely busy from everything you've just told us.
No problem. Thanks a lot for the invitation. It's been great.
Thank you so much.
Thanks.